Hi everyone, this is Neel Raithatha, consultant audiologist and director of WAXscope. Thank you for joining me in another demonstration video of our soon-to-be launched WAXscope, which is actually launching on Friday, the 12th of April. And here we have a patient with really soft and loose earwax and dead skin, and it can be very difficult to perform microsuction with this consistency of wax because it can continuously block the suction probe. So I did use some olive oil spray later on in the procedure. So here I'm just mopping up a bit of the entrance, and they've got an extremely twisty and bendy ear canal. So I've just cleared the entrance, and now I'm going to go deeper. I've just reduced the exposure so it's not as bright, because when you've got a lot of skin content, dead keratin, it can be highly reflective. So I've just turned that down on the app. And now I'm slowly but surely just performing microsuction. Because of the consistency, we just don't know where this patient's eardrum is. So we've got to tread very carefully. I don't want to insert the suction probe in too deep and far, because it may well be that the eardrum is right behind this very soft consistency of wax. So I'm just being a bit cautious. So there I've just put some medical grade olive oil spray in. And that helps to change the consistency. It makes it just a tad easier to perform microsuction. It almost acts as an emulsifier. It binds the wax together. I'm just coming back to the entrance, just to the floor of the ear canal, just trying to separate some of this skin off the canal wall so I can start seeing some of the ear canal. Seeing the ear canal is really important, because when you've got consistency of wax like this, you just don't know how wide and where exactly the canal wall is, and we don't want to poke into the canal wall. So now that I reveal some of the ear canal, it gives me some perspective into the ear. So this is more on the posterior canal wall, so the back section. Again, I'm just going to hover over, and as I'm suctioning, I'm coming back towards myself to the entrance to peel this skin away, and then I'm going back forwards towards the eardrum. So I'm just working this dead skin. Okay, I'm just going to dilate the ear. So the speculum we're using is our medium-sized speculi. It's a 4.25mm specular. And we have got a smaller one, it's 3.5mm, and a couple of larger ones, a 5mm and a 5.75. And the difference with the WAXscope compared to the iClearScope, Endoscope, is just the magnification. You got much more of a narrower field of view, and that's because of the magnification. At the top, there's a little opening, which now gives me a bit more perspective of how deep this wax is and how much room I've got to play with before I come near to the eardrum. So I've just put a bit more oil in. So I have performed the procedure. This patient comes every 6 or 7 months. They're suffering from chronic wax impaction. So I've performed it on several occasions using the endoscope, and I must say I was quite surprised of how well it went with the WAXscope, purely because even though just because this patient's ear canal is really, really bendy, so we need to get the speculum in and dilating it, and that's one of the benefits of the speculum, but I'm just so used to doing it with the endoscope. So I'm just constantly getting it back in focus. Again, I'm hovering over, and I'm just searching now for the eardrum. I just want to see some of the eardrum reveal itself, and it is at the top. I'm at the front part of the ear canal, so I'm just moving the specular as well in that direction so I can gain access. And slowly but surely now, the patient's beginning to hear a lot better. So even at this point, the patient reported that they can hear a lot better, and that's just because you can see sound can get through towards the eardrum. So I'm just going to insert it, change the focus again. So now we're working directly on, or almost on the eardrum. So yes, I don't want to penetrate the suction probe any deeper. I just want to hover over, and hopefully it will suction away this soft wax. But I think I'm going to have to use some more medical grade olive oil spray. So why do we use medical grade as opposed to home olive oil, so extra virgin olive oil? It's all to do with the higher concentration of polyphenols, which is an antioxidant. So to be considered medical grade olive oil, I think it has to be 250 grams per kg, I think, of polyphenols. and because it's an antioxidant, it's got a longer shelf life, and it can almost mitigate the effects of any free radicals. So free radicals are highly volatile molecules and atoms that are in search of an electron to complete its outer shell, and excessive amounts of free radicals in the ear, and our cells in our body produce free radicals so through metabolic activity. And if you've got excess free radicals, then free radicals can start leading to cell death, the necrosis of individual cells. So antioxidants almost counteract that. It donates an electron to the free radicals to make them less volatile and reactive. So I'm just now working on this back part of the ear canal. We can see the majority of the eardrum, and we can now see the back section of the ear canal. There's now just some wax in the inferior recess there, and also in the anterior recess. So I'm just getting it in focus. Sometimes it can make it difficult in terms when you've got a light coloured wax and you've got a Caucasian ear, because it can almost camouflage the wax against the canal, which makes it more difficult to remove. So if, for example, this wax is a lot darker, it would have been a bit easier for me to differentiate. And here you get more of a differentiation. So now this is the anterior recess. So this is the difficult part. Again, if it was a bit firmer, it would have come away in a big chunk, but it's not. It's very loose and wet, so we just got to hover over it, let the suction do its work. Again, we're going to avoid that front part of the ear canal. So the inner 2/3 of the ear canal is made up of bone, and it's a very thin layer of skin, less than 0.1 millimeters in thickness, lining the bone, so it's very sensitive. The outer third of the ear canal is made up of cartilage, and it's got a thicker layer of skin, 1 millimeters in thickness, and that skin contains a layer of fat and the hypodermis layer. So it acts as a buffer almost. So you can put a bit more pressure there in the cartilaginous portion. So it just zoomed in a little bit as well. You can't over zoom. If you over zoom, then things will get too magnified, which is counterproductive as well. But the image will get a bit grainy as well. So just got to zoom in just enough. Okay, just a little bit there. We're just going to try and get this away. The patient's hammer bone, you will notice it's slightly, you could call it abnormal. It's got a bit of it. The eardrum doesn't look like a textbook eardrum, although all the landmarks are there and it's healthy. It's highly vascularized. You see a lot of blood vessels and capillaries there. So I'm just mopping up now so the patient can hear really well. This is more near the entrance on the back part of the ear canal, so I'm just using the speculi just to dilate the ear, just rotating the speculum a little bit as well. And a bit of skin. I think I stopped in a moment because we're getting a bit of clarinetting, so we don't want that. Clarinetting is when you suction dead skin, it can violently flap and it can emit a very loud, high-frequency squeal, which can be not only loud for the patient, but also loud for myself. So in a moment, I think I experienced them, so I just stopped. I think it was that stage. So again, just want to hover over, I don't want to poke against the canal, just see I'm just kissing the surface, I'm just getting some of the excess oil out here. There we are. And there's just a little bit again on the posterior superior canal wall. So this part of the ear canal is innervated by the facial nerve. So sometimes when you work on this part of the eardrum, patients can get a bit of runny eyes, and that's because the facial nerve also stimulates the lacrimal reflex. The lacrimal glands are situated on the top corners of our eyes, at the tear ducts. I often get it when people are practicing in my ears. If they don't even have to be on the that part of the ear canal, just experience the runny eyes. And if I was working more at the bottom of the back part of the ear canal, you can initiate the Arnold's nerve, and that can lead to a gag reflex, a cough reflex. People can also experience faintness. They can actually faint. So again, I'm just zooming in here. course, it's going to be really delicate. So I'm happy with that, especially for a bendy, twisty ear. It's just a bit of staining on the eardrum there with a bit of soft wax, but it's not worthwhile. I shouldn't remove that anymore. You can see that annulum malleus, it just looks, it's very vascular. And that's normal, so for the patient, it's just that there's... So I'm just moving on to the right side. It's not as blocked, you can see there's a gap at the top. Very soft wax still there, but it's just a bit firmer, so it's going to come out in a bigger plug. So it's a bit more straightforward than their left side. So if you are a clinical ear care specialist or are super qualified to get trained in performing earwax removal, and you want to know more about the WAXscope, please do email info@clearwax.co.uk. So I'm just mopping up a bit here at the entrance. And you can see a bit of skin. So again, I'm going to just peel a bit away. If it starts to clarinet, we're going to stop. So I've just come back out. I'm going to dilate the ear, just look at the bottom part of the ear canal now. Again, just a bit of dead skin. I think we get a bit of clarinetting in a moment. We'll just see. So with the focus, when objects are near to you, you reduce the focus, and when objects are further away, you just increase the focus. So it's similar to an ENT microscope. With the microscope, you'll move the whole optical unit forwards and backwards. Here, you've got a slider where you can do it. So again, just going to visualize the eardrum. You've got a really clear view there. That's going to bring down the exposure, the brightness a little bit. It's quite reflective. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.